माइक बल्कि ले ले. Bismillahirrahmanirrahim. So we will start the next session that is on retrograde CTO PCI, and this is going to be an interactive session, and we would like you to participate as much as possible and stop us in between whenever you feel like. So we would like you to understand the retrograde approach right from the very basic. So myself and Dr. Saeed Alam will be conducting this session. Next slide, please. So, ये मुझे भी एक दे देंगे. ये क्या है? अच्छा, ठीक है. नहीं, ये एक पॉइंटर उसको भी बेशक दे देंगे यार. बट ठीक है. Can we go one back, please? So why do we think of going retrograde? So we follow the hybrid algorithm, and first of all we do a dual caster angiography, and we figure out how clear is the proximal cap, how good is the distal target, and what is the length. So if the proximal cap is not clear, we don't have a good distal target, so we think about going retrograde. And if the lesion length is more than 20 millimeter, again, these are the three things that will tell us whether we go antegrade or retrograde. So again, the same thing, the proximal cap is ambiguous, and there is a long lesion in the CTO course, which is greater than 20 millimeter. The distal landing zone is not good, and the vessel has a distal bifurcation. So all these conditions will lead us to think of going retrograde. So planning and geography is the key. So you ought to have a dual caster unless you have ipsilateral collaterals. So there should be a large field of view, and you should do it in an unmag fashion to get a large view. And there should be no panning, so you can clearly plan and understand the collateral channels. And it should be a long angiographic run to see all the connections. So for example, this is an RCA CTO. This is a post-cabbage patient. The proximal cap is ambiguous, and we don't know what is the course of the RCA. So this would not be a good case for antegrade because of these reasons. So now planning is the most important thing. You need to watch the angiogram for at least 10-15 minutes. So what happens is that when you initially see the angiogram, and what you see after 15 minutes is totally different. So you need to really understand the anatomy and the various collateral channels. So then you do the septal analysis, which septals are connecting. And for example, here we are showing various septal channels which are connecting with the right coronary artery. Then the other options can be the epicardial channels, but we should try and go to the septals first, because that's always a safer option, and the epicardials should be only sought as a last resort. So now I request Dr. Saeed Alam to show his case.
This slide actually shows us the different septals which we are using for crossing from the retrograde route. So as we see, there are mainly three septals, S1, S2, and S3. Next. Next.
Next, please. Next.
In the septal, we see the entry angle, the exit angle of the donor as well as the recipient artery. We see whether what is the size of the artery, are there any bifurcations, is it straight or tortuous, what is the diameter of the septal. Next, please. So these are certain things which we see in the retrograde septals. Next. Okay. So before starting the retrograde, first and the most important thing is the choice of the guiding sheaths and the guiding catheters. Usually we should take a longer sheath like 35 centimeter or 45 centimeter for maximum support. And the choice of the guiding catheters. For retrograde, it should be at least 7 or 8 French guiding catheter. And the left, it is EBU 3.5 or 375. For the right, it should be AL 0.75 or short AL 7 or 8 French. And the length should be 90 centimeter. This is important because if we take a longer guiding catheter, there we can come across a problem of taking the microcatheter retrogradely into the integrate guiding catheter, which we will discuss later in this in our cases. Now, first we take the wire. So which wire one should take? We initially take a workhorse wire and we give a double bed curve to this wire. We get this wire into one of the septal. And over that workhorse wire, we took this Corsair Pro microcatheter into the septal. Most of the time it is easy to make a bigger curve to the wire and cross it into the septal. But at times it is difficult to gain access into the septal. So what will be the options with us? If, for example, there are, the septal is arising retroflexly from the LAD. In that situation, what we do is that we could take angulated microcatheters like the Supercross or Venturi microcatheters. We could even take the double lumen microcatheters, or if these fancy microcatheters are not available, we can give a reverse loop to the wire, a polymer jacketed wire, and we could enter into the septal. Now the next thing is septal crossing with wire. So there are two ways in which we can cross a wire across the septum. One way is, as we see in this, play it a bit.
इसको play कर दीजिए, play.
Yeah, play kar isko. So there are two ways in which we cross the septum. One is the contrast guided crossing and the other is non-contrast guided crossing. In the contrast guided crossing, it could be selective or non-selective. In the non-selective, we give contrast through a guiding catheter. But in a selective, as we see in this case, we take small amount of contrast in a small syringe and we give a gentle injection and see whether there are any connections from the septum into the PDA or distal RCA or not. The other way is a technique which is called septal surfing. In this technique, what we do is that we take a soft or a steerable wire, which is non-polymer jacketed or could be a polymer jacketed or an hydrophilic wire, which is least traumatic. So the choices are different. One of the wire is the SO03, which is the lightest wire with a tip load of 0.3 gram. And it is hydrophilic, non-polymer jacketed. And also the Sion, which is also hydrophilic and non-polymer jacketed. The polymer jacketed options we have.
Dr. Saeed Alam, What would be your first choice of wire when you are crossing a septal for the audience?
It depends on the type of septal. We look at the tortuosity of the septal, the size of the septal, and then we decide accordingly. In a tortuous vessel, we can take the SO03, and in other vessels which are not visible, we can take the cyan black or cyan. So what will be your choice? And
Normally, I think a cyan wire is probably better. You are better off to start it with a plain cyan wire, and then you can sort of change into cyan black if required. Normally, SO03 you can utilize in septal collaterals as well, but it is generally reserved for epicardial collaterals because it's a very soft tip, but you can use it here as well.
Dr. Salman, what will be your choice of wire for crossing the septum?
I think you're absolutely right. So, Joe, if it's a proximal septal, then typically I use a cyan with a workhorse wire to get into it, and then I use a cyan black. So, if there's cyan here, I'll use a cyan black. And again, like you said, the bigger tip will be on the cyan, and the smaller tip will be cyan black. I'll do that. The other thing is, if it's not crossing proximally, then I will do the tip injection with the contrast, because I think just like you showed, even though there wasn't a whole lot of connections, sometimes that contrast will open up some microchannels, and then try the cyan black again. So that's one thing. SUO, I think you made a good point, because SUO actually doesn't work as well in the muscular collaterals, and in fact, the more you torque, it turns into a knot, and it's very hard, you lose the wire, so you end up wasting a wire. But interestingly, if you look at the distal septal collaterals, those oftentimes have a short epicardial course, which makes it a little difficult, challenging also. So if I go very distal, if I'm doing in the lower third of the LED, then I might use SUO in that case. But proximally, I would use cyan or cyan black, and just at the very distal tip of the LED, if the regular wires are not going, then I would use a SUO3.
So in the septal surfing, as you see, rapid rotations are given to the wire, to and fro, back and forth movement of the wire, and then there is sudden release of the wire, and it finds its way into the distal RCA.
So septal surfing you are doing blindly. There is one method in which you inject through your microcatheter, find the pathway of the retrograde channel into the right coronary artery. But if you don't see any channel, you can just do septal surfing, and sometimes channels that are not visible by contrast, you can get access through septal surfing.
So if the
So if you have a bunch of septals that are feeding the RCA, and in choosing, which one would you choose? Would you go as proximally possible or as distal as possible?
Please comment.
I think that's a great question. So I generally like to use the most proximal one. So the septal 1 and the septal 2 is the one that's most likely to get you into that. Now the only caveat there is that sometimes you have a big first septal, but then it has multiple branches. And then you can use the tip injection to direct yourself into those branches, right? So you've got 4 branches, you've got pehle wale mini, then the second one, the third one. You can like do that. So usually for directed septal surfing, the first and second septals are great for that. The only thing is sometimes if it's not apparent to me in the RAO cranial view, I use an LAO cranial view because the septal may have actually be coming off from a different location in the LED. So I can't get into the septal in the RAO cranial view. I'll use the LAO cranial view, and sometimes it's coming off a diagonal branch, for example, just overlapped. But if it doesn't work in the proximal portion, then I do blind septal surfing in the mid portion, and sometimes that will work. So,
with a good septum to the RCA, if we are talking of anything, what would be your approach?
so if the disease is caused, sometimes septals are diseased, you can angioplasty that with a 1O balloon, or a 2O balloon, but more often than not, the problem is you've already fixed the area, there's a stent there. Then you get the wire through there, and you can't get the microcatheter. So in that case, I will put a balloon there, open up that ostium and the stent strut, and then get the microcatheter and then use one of these techniques.
Correct. It kind of just generated another question in terms of viewing the septals. So very often we see that the septals would be better off viewed in one view or the other. Of course, you could always go by guesswork, but what are your, so to say, workhorse views for proximal and distal septal visualization throughout the process?
It's classic. So I always start off, if I think of retrograde to the septals, I will do a eleocranial and areocranial. So I do those. Sometimes I will actually go outside of the room to the monitors outside in the monitoring station, because the way you look at the septal is you pause the image where you see the target vessel, and then you click backwards to see what filled it. Right, so which septal to use? Because if you just look at the picture, in real time you can't see you have 20 septals coming down. But what you do is you take your pictures in the two views without panning, as they pointed out, and then I'll pause, and if I can't see it in the room, I'll go outside to the monitoring station and have someone do it back. Then I start going backwards, see where the PDA first lights up, and then slowly click backwards until I see which is the collateral, backtrack it to see where it's coming off. And that's a good way of identifying. And then sometimes if I'm doing the more distal ones, because they tend to be more angulated from the PDA, then I might do something like an areocaudal view if I'm trying to get from the PDA to the LAD. But LAD coming down, typically I use a combination of eleocranial and areocranial.
For CTO PCI, it is important to have, particularly for retrograde CTO PCI, to have plan A, B, C, and D ahead of time in your mind. So to overcome the challenge of septal not being crossed by the wire, what will be the options with us? So we check that there are three main septals. So the next step, which is least cost effective, is to change the septum. So we have changed the septum, and now we have started the same technique of tip injection and septal surfing, and we are crossing from the second septum.
And which wire are you using in this?
It is 203 wire. Now again, it is not successful. So what we did, we are trying the third septal. So again, the same two techniques are being tried. So if all of the three septals are not crossed, what will be the options with us? One is to change the wire from one to another. For example, we can take a Sion black or Sion wire. The other way is to go from epicardial collaterals. Or according to the hybrid algorithm, you can change from into a retrograde into the integrate. Now, as we see, we have crossed the septum with the wire.
And which wire crossed?
It is the SO03 wire, yeah. So the wire takes a course, and then it is pulled back and redirected. And as you see, it is sailed right into the mid RCA. Over that wire, it is now we see. So the next step is crossing the microcatheter over the wire. So this is the next challenge for us. So as we push the microcatheter, this is caravel microcatheter, this is in another case. So as we push the wire, as you see, the guiding catheter is kicking back, you see. So this is the next challenge for us.
So it is very important to have the support both in the antegrade and the retrograde guide catheters. You can see that he has got an implants one here and an extra backup in this. And at times you can even need to have guideliners to increase your support.
Yeah. So we have different options. So first we try those options which are least cost effective. So these are different options. Rotation, we already tried this method. We already tried this method of rotation. Increase the support. The support is already with a 7-French EBU 3.5 guiding catheter. Or we can use a guide liner or a balloon anchoring technique, which we'll see in our next case. Then dilate the collateral with a small balloon, or the other three techniques we will see in our case. There, the number 3, 4, and 5 techniques are to change the microcatheter. So this is a bit cost-effective technique, but it is most of the time effective. We can change from the caravel microcatheter into a more torqueable and penetrating microcatheter like the Turnpike or Corsair Pro.
And so which would be your microcatheter of choice in a septal collateral and in an epicardial collateral?
I think that the best catheter, I think these days is the Corsair Pro XS. But now we have two choices. Either
Both
Corsair
in the septal and epicardial?
Epicardial. For epicardial, low profile catheters like the Caravelle or Fine Cross are
So
good.
Caravelle is probably the lowest profile catheter which is more suited for the epicardials.
Yeah.
And a catheter with rotation like a Corsair Pro XS is probably better in a septal collateral.
Dr. Salman will tell us his experience of comparing the Corsair Pro with Turnpike and crossing the septum.
You know, so I use mostly Turnpike LP.
Yeah.
I like it because for me that's my workhorse microcatheter. So I would say that 90% of my cases I do entirely with antegrade, retrograde with Turnpike LP. And so if that doesn't work, then we don't have Caravelle. Sometimes what I've used is actually a fine cross. So believe it or not, a fine cross may cross in that location. Once I had to use a Mamba, but ultimately I think one of the simplest things you can do is, if you've been trying for a while, the catheter tip becomes a little dry, and when it's dry, it doesn't move. So simplest thing, in addition to doing all of this, you can increase the support, is just to disengage, leave the wire where it is, move the microcatheter back, put it into the main vessel, give it a few seconds, and then try again. And that re-lubricates the tip of the microcatheter. But generally, I use Turnpike LP.
What about the Turnpike Spiral or Turnpike Gold and crossing the septum?
No, neither one. So Turnpike Spiral is too bulky because we've got the extra nylon. I think it would traumatize the septal. The septal is relatively small. So you can use a Corsair, you can use a Turnpike, but not a Turnpike Spiral. And for epicardial, for the same reason, because epicardials are very easy to avulse and cause trauma. So anything bigger than the Corsair Pro XS, or actually anything bigger than the Turnpike LP or Caravelle will be too traumatic. Now gold you can use if you've crossed a microchannel but you need some grip on it. But in my experience, if you have enough support, a Turnpike LP will do the trick. You don't need a gold.
Okay. Another way is to use a tonus microcatheter or to change the length of the microcatheter. From usually for retrograde we use 150 centimeter of the microcatheter for easy crossing into the antegrade guide. But actually, we can change it into the 135 centimeter.
Turnpike Gold and the tonus catheters are usually used in antegrade and when the plaque is very hard or calcific to modify the plaque. They are not usually used in a retrograde fashion.
Yeah.
Yes, absolutely.
So another way to increase the support is balloon anchoring. As initially I told that we should take 7 fringe guiding catheter because that's easy. And in our next case we will see balloon anchoring technique of crossing the microcatheter across the septum. Now we are removing the microcatheter through trapping technique, balloon trapping technique.
Can you please explain this technique?
Yeah, so there are different ways to remove the microcatheter. One is the balloon trapping technique. There are certain dedicated trapping balloon from Boston and from, so we can use those dedicated trapping balloons. We put those balloons inside the guiding catheter. The length is not that long that it moves out of the guiding catheter. And we trap those balloons inside the guiding catheter ahead of the microcatheter. And then we trap the wire and we pull the microcatheter so it is intact, the wire is intact and it's not moving inside the coronary vessel. The other way is to use a wire extension. Wire extension can also be used. We can also use the ordinary coronary balloon 2.5 for 7 fringe guiding catheter and 2 for 6 fringe guiding catheter, but that's not a good option. Now, play it a bit.
Play कीजिएगा.
Now, so the least cost effective technique was to take a balloon which is low profile, like 1.25 or 10 balloon. In this case, we have taken Sapphire 105 balloon, and we are pushing this balloon. As you see, again, the guiding catheter is backing up. So again, it is not successful. Crossing of the balloon is also not successful. And we are going to dilate the channel through it, and then we could possibly cross the microcatheter across it. It is 105. Now, there is a debate about the length of the microcatheter. I don't know which length of the microcatheter, length of the balloon, sorry. Length of the balloon. I don't know which length of the balloon will work more, whether 105 or 110 will cross easily. But this 105 couldn't cross.
Sometimes you can just inflate the balloon at a very low atmosphere just to create a little bit of space for your microcatheter to cross.
No, the last options we have is to cross the wire without the support of the microcatheter, and then we try to go retrogradely into the antegrade guiding catheter. But it is most of the time not successful because we cannot change the wire and this is least support. So in this clip you can see that the retrograde wire is being tried to cross retrogradely. Now, another way is to use this retrograde wire as a marker and go from antegrade. As you see, we are taking the confianza approach 12 and we are moving from antegrade into the retrograde and using this retrograde wire as a marker. So we are successful in this. As you see, the confianza is crossing. We are checking it in orthogonal views. So this should be confirmed in different views, whether we are in true lumen or not. Now, when all the techniques of crossing the septum fail, then one way is to go from epicardial collateral. So as we see in a case, there are clear epicardial collaterals, so we can go from, if they are there, these are there, we can go from epicardial collateral. Dr. Nadir will tell us about his case of crossing the epicardial collateral now.
ये मेरे कंप्यूटर वाली स्क्रीन शेयर कर लीजिए. Please.
It's a very nice case. It's always thinking about retrograde technique. Why not you first try this patient is antegrade technique?
It was already tried, but I just showed you the retrograde techniques only because our discussion was on retrograde. So it was according to the hybrid algorithm, it was initially started antegradely, then we failed, and then we went retrogradely. Yeah.
Okay. Sir, one more question, please. Sir, about this septal check injection, should we take it in the proximal segment of the septal collateral, or we can take it very distally when the diameter is very small and there is a risk of damaging the collateral and the whole procedure can be abandoned?
That is very important. Whenever you have to give a septal injection, you must aspirate the microcatheter and there should be blood coming into the microcatheter before you inject. Because if your catheter is wedged and you inject forcefully, you can damage the collaterals. So it should be a little proximal. When it should be at a place where you can aspirate blood. If you can't aspirate blood, pull it a bit proximal, aspirate blood and then inject.
Okay, that's right. Aspiration is needed before.
It is very important because otherwise the catheter is wedged and you can damage the collaterals.
Okay, thank you.
I have a question about septal hematomas. So if you have a septal hematoma because of the surfing, does that define the end point of your procedure and trying at a later date? How worried should we be about septal hematomas?
Oh, yes, that's a good question. Generally, septal hematomas do not cause much trouble. So they are localized inside the septum. It is very rare to have them cause a hemodynamic compromise, but sometimes they can do. And
do we need to stop and come back at a later date, or just continue through a different septal?
I think small septal hematomas should not let you stop the case. You can try other channels as well, and Dr. Salman can comment on this.
I agree with that. I think it depends on where the septal hematoma is and how big is it. If you're in a proximal septal and that was the only good option and now there's a hematoma, then you don't have any options, you're done. But I think if you got other septals you want to try, and let's say you're trying this S2 and you got a hematoma there, but it's fairly localized, the contrast stain isn't growing, then you can go to S1 or S3. I don't think it should necessarily stop you unless you start seeing some hemodynamic issues. Because sometimes it's not so much that. Sometimes the movement of the guide can cause a little dissection or thrombosis. So there are other challenges in doing a retrograde which would make you stop, but a hematoma alone probably is not it.
Is there any specific way of identifying the working collaterals, Dr. Saeed?
Excuse me.
Is there any specific way of identifying the working collaterals, or you just need to just, keep on trying one by one the different collaterals?
It is important to take the whole view of the septum, and we see 4 or 5 things in the septals. It's entry angle, its exit angle, its diameter, whether there are bifurcations or not, is it straight or tortuous. We analyze everything, and finally we decide which one is the best.
Excuse me, one comment, Saeed?
Yes.
One comment about the septal approach. The septal hematoma formation or perforation is not of grave consequences because the septal branches are already contained within the sheath of the muscles, and even if the artery is perforated into the lumen of the heart, the blood doesn't go anywhere else. It is recirculated in the circulation. So that should not be the end point to call it a day. I think one can continue, you can shift over to another septal.
One point is that some of the apical septals, when you cross from the apical septals, and a perforation there can cause epicardial, cardiac tamponade or leaking.
You should
of
avoid
blood into
septal area. This is the basal septal area is better safe.
Saeed, I have a question. So when you were doing the integrate later on using a CP12, did you just puncture the cap and change the wire, or you just cross the whole body with the CP12 into the recipient vessel?
Yeah, I initially tried the polymer jacketed wire fielder XTA, then Gaia second. I tried the Gaia second, but before taking the Confianza Pro 12, as the cap was ambiguous, so I tried retrogradely. And when the retrograde technique failed, I just took the CP12, Confianza Pro 12, and punctured the cap. And
did you try IVUS guided puncture, or
no?
There was no side branch.
I was guided puncture.
So now we'll be sharing a case of an epicardial collateral retrograde approach. So this was a case of a circumflex CTO in which there was an attempt, antegrade attempt, which was unsuccessful. The wire went extra plaque. And then we took these pictures. So now this is a very important picture. You can see that this is an unmagged picture, and this is without panning, so you can see this epicardial collateral connecting the distal right PDA, and it is going into the OM branch. Now, one thing about the epicardial collaterals is that your retrograde guide should be shortened. Normally, the guide catheters are 100 centimeter and they should be shortened. You get 90 centimeter guide catheters, company made as well, but usually we don't have them here, so you have to shorten them. And there is a technique which, if we have time, we can show it later on. So now we have a 7 French Judkin Wright guide because we couldn't get an AL to sit in the right coronary artery. So for support, what we have done is we have put in a wire in the conus branch, and there is a balloon inflated there which is giving us support. So we have a Corsair microcatheter with a workhorse wire. Now the Corsair has advanced into the epicardial collateral, and we are taking a tip injection to see the course of the epicardial collateral. So now we are following this with the Sion black wire, which successfully crossed into the circumflex.
Didn't you take Suho 3 wire for epicardial collateral?
Actually, we don't have SUO3. I don't know where Dr. Alam gets them from, but in normal centers, at least we don't have it in AFIC. And Dr. Alam has...
for transverse collaterals, specifically Picardial, this is the best wire, the SUO03.
But he has to tell us where he gets it from. He doesn't tell us that.
It is confidential.
So we don't have a SUO03 wire. Ideally, in an epicardial collateral, it should be a SUO03 wire, which is probably the safest because perforation in a epicardial collateral can be catastrophic.
And which microcatheter is it?
This is a Corsair microcatheter. So our microcatheter has reached the left main, and the wire is the Sion black. And luckily, we were lucky to cross sort of lumen to lumen. Normally, at this stage, you have to do a reverse cart to sort of get back into the true lumen.
Now we can come across the difficulty of crossing the CTO cap and CTO body retrograde. So it is almost the same. We escalate and de-escalate the wires. Initially, we take polymer jacketed wires like the Fielder XTA or Fielder FC. Then if it is not punctured by these or it doesn't find its path, then we increase the tip load to a Gaia second or even a Hornet 14 or Confianza Pro 12.
So now we had the another step, next step is to put the guide wire in the guiding catheter. And we had great difficulty in doing that. And then we took a Guidezilla and tried to advance it into the left main, and so that our wire can sort of enter into it has a smaller target to enter. But we were not successful in this regard as well. And then what we did was that we took an RG3 and snared it into the guide catheter. So then we sort of externalized, and then
can you do Carlino at this stage?
Sorry?
Can you do Carlino at this stage?
No. Carlino is an anti-grade technique, although you can do retrograde Carlino as well. But as our wire had crossed lumen to lumen without much difficulty, and it was a Sion black that probably crossed, so that's why we didn't have to do a Carlino. You need to do a retrograde Carlino only if your wire is not making progress, so you can just do a Carlino there retrogradely.
So we can come across certain challenges while crossing retrogradely because the wire may not go into the lumen inside the plug. It may go outside the plug or an extra plug space. So in those situations,
you want to say something?
I think you both are doing CTOs, and we are not doing in many cath labs in the country. Just want to know what is the burden of, or how many cases do you do, or Dr. Alam, in a year, and what is your success overall, generally? And I would also like to know, in the hand of experts like Salman, what is his success rate in a retrograde approach?
Comments? Sir,
from you
we don't
too.
do retrogrades very routinely. It's generally we try what majority of our cases are anti-grade, and now because of these Gaia wires, the Carlino techniques that we have learned, so our success rate would be, I would say, around 90% with these techniques, and anti-grade success is ever increasing. So retrograde is sort of as a last resort. If we are not successful, only then we do. Dr. Alam.
So we have done a few retrograde, and in those situations where the anti-grade techniques are already failed by elsewhere or by myself, and the next go I call the patient and then assess everything, whether the collaterals are good or not, everything is okay. Actually, these are the super selective cases, not like outside that every case is taken, any case can be taken for CTO. So these are actually super selective cases of CTO.
I think 90% is an excellent success. We would love to be under your supervisorship for such a high success. We can start at other places as well, I think.
I think, so I think that's a great point. I think the real answer is case selection. So if you choose your cases properly or well, and this comes with experience, then I think you can get 90% or so. So I think for those short, with antegrade, even some of the more complex ones, they're not so short, you can do it. For retrograde, it all depends on your experience. When I started off, my retrograde success rate was very low, maybe 10, 15%. Now it's probably close to 70, 75%. But again, I have done a lot of antegrade and failed before I get to retrograde. So my focus usually, I would say that in a year I do about 120 cases of CTU, let's just say for example. I would say the vast majority are done antegrade. The only time that I do retrograde is if I've tried antegrade and it hasn't worked, or if there's a vein graft that's failing and I can use that before it shuts down completely. So I think vein graft retrograde is much easier to do than epicardial or septal. And epicardials, I don't think I do more than maybe 5 epicardials a year, if at all. It's a rare thing to do.
So just a bit away from the topic, although basically it was the retrograde technique we were talking about. But your general approach is, do you always try antegrade, and failure to advance antegrade, you then start, your approach converts into retrograde? Is that the routine approach?
Yes, that's generally true. And in this particular case, if you see, our wire had got subintimal. So there was a good distal target in the circumflex. If we had a Stingray system with us, the ideal approach would have been to do a antegrade dissection re-entry in this particular case. But as we don't have the antegrade dissection re-entry systems, so that's why we opted for the retrograde approach in this case. The only downside of the retrograde approach is that it has a steep learning curve and it has more chance of complications. 5 times more chances of complications as compared to the antegrade approach.
Once I read a case report of septal hematoma that leads into internal tamponade, and they has to drain the hematoma into the cavity with puncturing it. And 2 questions. When will be retrograde as your first choice?
Yeah, very good.
And number 2, can you also tell us the technique that how to pull this balloon out of this collateral, because it may damage it.
So you mean your balloon has been trapped and you...
No, it has gone. You have completed the procedure. Now you have to take it out.
Okay. We'll talk about that, yes. That's very important because bad things happen when you pull the gear out. So that is very important. I'll show you that. And what was your initial question?
When will be retrograde first, as a first choice?
If you remember our first slide, you ought to have an ambiguous proximal cap, number 1. Your proximal cap is ambiguous. Your CTO length is more than 20. You don't have a good distal landing zone. So these 3 things have to be there.
What about ostial CTO? When your CTO is ostial?
That could be another thing, because in an ostial CTO, generally the proximal cap is ambiguous. So if your proximal cap is very clear, even in an ostial CTO, you can try antegrade. But if it is not clear, your CTO is more than 20 centimeter, you don't have a good distal landing zone. And 4th thing is that you have good interventional collaterals. That's very important, to have good interventional collaterals. And what are interventional collaterals? In which you are confident that you can gain access from the retrograde approach into the sort of antegrade.
Other than ostial flash occlusions, in any ambiguous cap occlusions, we should initially attempt the antegrade, because sometimes the patient, and you are lucky and you find a path and can go antegrade.
And another point is that if you have a bifurcation at the distal cap, so if you have a bifurcation at the distal cap, you go antegrade subintimally, you are bound to lose one of the branches, especially in a distal RCA. So that is another reason. So these will be the ambiguous cap, long CTO, don't have a good landing zone, and you have bifurcation or significant branches in the line of your CTO. And fifth one is that you have good interventional collaterals. Mohsin, do you have?
Sir, first question is that you've shown the first slide in which you said that these are the criteria for retrograde up front, like 20 mm, ambiguous cap, whatever. In these cases, you don't even try antigrade? Do you go straight away for the retrograde? This is first question. And the second is, because you just mentioned the high complication rate in retrograde, would you attempt a retrograde in someone who's completely asymptomatic, but who's got severe ischemia on the thallium scan? Would you please respond to that?
So I'll answer the second question first. So it is very important to have symptoms in a CTO. Although symptoms might not be the classical angina symptoms, they might be just dyspnea on exertion. But generally speaking, my practice is that if the patient doesn't have symptoms, and even if he has ischemia on a thallium scan, I will not attempt that CTO. And your first question was that, sorry, can you? Yes, yes. If the cap is ambiguous, it's a long CTO, not a good landing zone, and you have bifurcation, so the chances of antigrade success are very low. So you might have to go primary retrograde in this particular case.
Right. Sir.
So, yes, please.
Sir, my name is Dr. Hamza Zurghari. Just had a question. So wonderful session regarding retrograde CTOs. So we've talked about the algorithm, and we all know that we have algorithms like the hybrid algorithm, then we had Asia Pacific algorithm, and then the Japanese algorithm in 2019. So how much time do we spend for the antigrade approach? Some say it's 20 minutes, 20 to 30 minutes. So how much time do we need to spend, or if there is something else that we look for?
So this is very important because you don't have to persist in a failure mode. So if you think that you are not succeeding, let's say 10 to 15 minutes in antigrade wiring, and you have good intervention collaterals, or you have some other options. So you can not only, you can change the wires, you can do different things if you are in a failure mode. So I think 15 minutes should be a good enough time. Dr. Salman, you want to say something?
Okay. So this is a very important question. और उसका जवाब ये है कि it takes time, right? So ये 15 minute, 20 minute, आधा घंटा, this is for experts. These are the people who do this day and night, right? When you're starting off CTOs, those time limits don't apply to you. When we started doing our CTOs, so मेरा पहला जो proctored case था was 4.5 hours. उसके बाद कम हुए, फिर एक case हमारा शुरू में was 6 hours long. Because my proctor didn't want to give up, I gave up, he didn't want me to give up. So when you start doing CTOs, the cases can take a long time. Ultimately, what you want to be aware of in a CTO is it's 100% blocked artery. अगर ना भी खुली तो that's okay. But अगर उससे खोलने के चक्कर में patient को कुछ हो गया, that's not justifiable, right? So you have to make sure कि contrast load, radiation time, और जो आपकी guide जो है, and make sure you don't cause a dissection, because and I've done all of this, right? So I'm not saying based on some textbook. I mean, this is stuff that I've lived through, and these complications I've had. So you've got to stop at some point. अगर आपका सारा lab बंद हुई है because you're doing one CTO, you don't have to do that. So I would say कि when you start doing CTOs, case selection is important. Try doing this typically what the experts call relatively low JCTO scores. Once you have more comfortable, then you can make it more and more complicated. But even those simple cases which for an expert would take, like that case I showed you in the last session, took me an hour and a half. But if I'd started off, that would take me about 6 hours.
Thank you.
So this is a very important point Dr. Salman has made. In a CTO case, failure is acceptable, but complications are not. So you have to be as safe as possible and accept failure and learn when to stop rather than pushing hard and creating a complication.
Sir, I just
Dr.
want
Salman,
It also depends on how frequently you are switching your inventory. So if you are going to do the same things again and again and you are wasting time on that, so these minutes are not counted in that way.
Sir, I just want to know
Saeed,
why you
just
got,
asking you guys the question, do you take help of imaging before embarking such procedure at times? CT angio?
Imaging with the, yes, CT angio can be helpful at times.
Do you take help them?
Yes, it does help at times, and I think it is, if it's a long CTO, doing a CT angio beforehand can be very useful.
sir,
And
I-
Dr.
sir, I-
Salman, how often do you do CT for such patient before?
So what was the reason for this difficult wire externalization? Because you need to do that snaring.
Yes.
And what should generally be the method for the beginners, how to externalize the wire? Because it often takes more push. The wire could not be moved forward into the integrate guide, even if it is RG3. So what we can do to externalize it? That is the main question. And secondly, where should be the second question? Where should be the micro catheter when we are externalizing the wire?
Okay. So when you are snaring a retrograde wire, always snare the soft portion of the wire, because otherwise, if you snare the harder portion, it can sort of buckle and you won't be able to free it from the snare. And don't snare very hard wires like an RG3 or, a Confianza Pro 12. RG3 is a good wire to sort of snare. And this is, I think, about all.
Generally, it enters into the integrate guide. We don't need to snare it.
Generally, it enters and you
Right.
can follow it with the micro catheter
Yes.
inside the guide catheter before you sort of start pushing in the RG3.
But if we snare it without a microcatheter across the left main and proximal circumflex, an effect which is a cutting cheese effect, can it harm the patient?
But you will
Where should be
snare-
the microcatheter if we are snaring it with a force?
स्नेर तो आप उसी वक्त करेंगे ना कि जब आपका अगर माइक्रो कैथेटर गाइड के अंदर चला गया फिर तो स्नेर करने की जरूरत ही नहीं है.
Yes.
माइक्रो कैथेटर पीछे होगा फिर ही स्नेर
Yes.
करेंगे.
In other cases, I am asking if it is not going into the integrate guide, then this cutting cheese effect, how we can avoid it?
नहीं तो अच्छा पहला सवाल तो इतना कि why couldn't you get into the guide because left में चौड़ी बहुत होती है right and जो भी guide बैठी हुई है angle पे बैठी हुई है so the wire comes off to one side and the guide is the other so it's very hard to get into that channel इसलिए इन्होंने guide extender use किया था but sometimes even then the left main is too wide जो cheese cutting effect है वो सब होता है अगर आप तार को खींचें across an angle, right? So angle कहाँ पे बन रहा है? या तो जहाँ पे PDA से जा रही है, यानी where you enter the collateral or where you exiting the collateral. So the microcatheter should be in a coaxial part of the vessel before you push the wire out to be snared. Because आप उसमें अगर खींचते हैं तो at least the microcatheter जो PTFE tube है उसकी will keep the wire from cutting into the muscle. I think that's the question you're asking.
One way is to disengage the guiding catheter while snaring the wire to decrease the effect of snare of this T-slicing effect.
My question to Dr. Salman, can we do tip-in instead of just externalizing?
हाँ, so I mean I like to do tip-in a lot, वो जिक्र नहीं हुआ. It's very hard to do tip-in in the left main, लेकिन हो सकता है. You know, the short answer is yes, but it requires anything. So tip-in में okay. So tip-in में ये होता है कि you need to have some curved angle जहाँ पे आप tip in करें because curved angle में ये हो रहा है कि on two different planes, in two different dimensions, that's the point जहाँ से wire has to cross and the catheter has to cross from the other side. So you can find that curved spot either in the curve of the EBU or usually on the top part of the arch. So you can also use that. लेकिन that requires experience and it saves you a snare, but हो सकता है tip in.
अच्छा, ये जो आपने point raise किया था, जब आप विड्रॉ कर रहे हैं माइक्रो कैथेटर वायर तो हमेशा अपना गाइड डिसंगेज कर लें क्योंकि वो वरना वो गाइड डीप जाएगा और डिसेक्शन करेगा और ये मैं आपको दिखाना, ये तो खैर दिस इज़ द पिक्चर ऑफ द सर्कमफ्लेक्स, और ये मैं आपको दूसरी तरफ, और अपना जो डोनर है उसकी भी आपने पिक्चर एंड में लेनी है. एंड दिस इज़ हाउ इट लुक लाइक वंस वी वर डन. सो यू कैन सी देयर इज सम थ्रोम्बस इन द प्रॉक्सिमल सेगमेंट. और वही वजह जो आप बता रहे हैं कि जब आप चीज़ें खींचते हैं तो these things can happen, you can dissect. And then we had to stent this as well. So it is very important to take care of your donor, take pictures of the donor before you end. So you have opened up the CTO, sometimes you can cause problem in the donor vessel as well. So you take a check injection and fix it if required. अगर आप कहीं भी वायर और माइक्रो कैथेटर खींच रहे हैं, हमेशा उस साइड का जो गाइड है वो पहले डिसंगेज कर लें काफ़ी ज़्यादा, फिर खींचें, वरना वो गाइड डाइव इन करेगा और वेसल को डैमेज करेगा. थैंक यू जी, थैंक यू वेरी मच.
डायरेक्टली आप इससे चेंज कर दीजिए, लैपटॉप से आपका चेंज. आप इनके, हाँ